So it's Subodh Dave. No, my name
Dave.
confuses people. It's pronounced with an E with an accent, so I have to remind. But no, that's okay. It's spelled like Dave, so it's a mistake easily made. But thanks for inviting me upon it. And I think if all of us think about what would it be to be treated like a person rather than a patient in a clinical encounter. So if when you go and see your doctor, when you go and see your nurse or physiotherapist or whatever, if you treat it as a person rather than a patient, what's the difference? And I think for me, I think it was an eye-opening moment, because I think the key thing that we have to realize is that even if you are a patient-centric doctor, patient-centered psychiatrist, if you are inherently viewing that encounter and seeing the person as a patient, then I think all of your dignity, compassion, respect, enablement, etc., is in the service of making a diagnosis and making a treatment plan. And that kind of drives you, because you think of it as a clinical encounter only. I think when you start seeing the person as a person instead, then you are genuinely curious about what is it they want, what is it they want from their, not just that encounter, but from their life, and how can you play a role in supporting that and helping that through your professional expertise. So being person-centered does not mean that you lose your professional expertise. And in many ways, this is central to what we do, or what we're meant to do when we practice evidence-based practice. Evidence-based practice is very much about not just applying research evidence to individual issues, but also to bring in their values, beliefs, ideas into the clinical decision-making process. And your people's traits, whether they be neurodivergent traits or whether there's the intersectionalities that Raj alluded to, all become relevant in the conversation. And then you're trying to view them not necessarily as deficiencies, but as variables that play a role. And sometimes they may be playing a positive role, and sometimes they may be playing a less positive role, or even a negative role. So I think that when you employ those person-centered care principles in education, in training, it increases and improves the effectiveness of the whole process, not only just for the learner, not only for the patient, so patient outcomes get better, but it also leads to more satisfaction, less burnout amongst the staff and the supervisors who are practicing it. So it's actually a win-win for everyone. So that's my point number one. I think is we put this element of person-centered care very, very squarely in our curriculum. So if you have looked at our new curricula, which have just started being piloted this month, and the proper rollout begins in August, and you will see that person-centered care features as the core element of our curriculum, indeed all our curricula. So yeah, core training curricula and the higher specialist curricula. Focusing specifically on neurodivergence, I think we've kind of really highlighted the importance of all factors that influence patient outcomes and how they need to be considered in the decision making. And then and I'm particularly keen on thinking of psychosocial evidence that has existed for some time but has not always been implemented in the curriculum and in our training and assessment. And so things like early life experiences, neurodevelopmental skills, I think, which would need to be beefed up in the curriculum, and our focus is really on that.